Hello students, myself Dr. Sabitha Gokulraj, Associate Professor from the Department of Oral Medicine and Radiology, Vinayaka Mission Sankaracharya Dental College, would be presenting today on the effects of radiation on oral tissues. These are the contents of my presentation where I will be dealing with the rationale of radiotherapy and trying to understand the effects of radiation on oral tissues, which includes the oral mucous membrane, the tongue, salivary glands, teeth, musculature and the bone. So what is rationale of radiotherapy? Moving on to it, oral cancer is one of the 10th most common cancers in the world. The treatment of oral cancer includes surgery, radiation therapy, chemotherapy or sometimes combination therapies. Radiotherapy for malignant lesions in the oral cavity is usually indicated when the lesion is radiosensitive, advanced or deeply invasive and cannot be approached surgically. The oral cancer is irradiated during the course of treating radiosensitive oral malignant tumors, usually squamous cell carcinomas. Combined surgical and radiotherapeutic treatment often provides optimal treatment. Radiotherapeutic treatment involves 2 grays of radiation per day for a weekly exposure of 10 grays, which is done for 6 to 7 weeks until a total dose of 64 to 70 grays is administered. This method of divided dose treatment is called fractionation, and there are various advantages of fractionation. 1, it provides greater tumor destruction than a large single dose. 2, fractionation characteristically allows increased cellular repair of normal tissues, which allows recovery of normal cells than tumor cells. Fractionation also increases the mean oxygen tension in an irradiated tumor, which renders the tumor cells more radiosensitive, thus killing the rapidly dividing tumor cells and shrinking the tumor mass. And we as dentists would definitely come across such patients treated with radiotherapy for the head and neck malignancies. We should also be able to manage such kind of patients with oral complications. But nowadays, a recently advanced 3-dimensional technique called the intensity modulated radiotherapy has been used to control the dose distribution with high accuracy, which is of greater importance of now, which minimizes the complications of the effects of radiation. Now moving on to the effects of radiation on the oral tissues, the first tissue, the oral mucous membrane. The oral mucous membrane consists of a basal layer composed of rapidly dividing radiosensitive stem cells, and because they are radiosensitive, they take up more amount of radiation. And by about the 2nd week of radiotherapy, some of these cells die and the mucous membrane begins to show areas of redness and inflammation, which is called as mucositis. As we continue the treatment, as it is not enough with 2 grays of radiation in the first week or 10 grays of radiation in the first week, the irradiated mucous membrane begins to separate from the underlying connective tissue with the formation of a white or yellow pseudomembrane, which leads to desquamation of the epithelial cells. At the end of therapy, the mucositis is usually more severe and the patient feels discomfort and the food intake becomes very difficult. Good oral hygiene has to be practiced by the patients to minimize infection. Topical anesthetics may sometimes be required at mealtimes for the patient, and sometimes it is usually secondarily infected by Candida albicans, which is the most common complication. After irradiation is completed, the mucosa usually begins to heal rapidly, and which takes about 2 months for the mucous membrane to become normal. But after that also, the mucous membrane sometimes becomes atrophic, thin and relatively avascular with fibrosis of the underlying connective tissue, which leads to ulcerations of the mucous membrane. This actually causes problem in patients wearing dentures. The next, the taste buds. Taste buds are sensitive to radiation, and therapeutic dose causes extensive degeneration of the taste buds. Patient often notice a loss of taste acuity during the 2nd to the 3rd week of radiotherapy. Bitter and acid flavors are more severely affected when the posterior 1/3 of the tongue is irradiated, and if it is the anterior third, it is the salt and the sweet taste which is going to be altered. and the taste acuity usually decreases by a factor of 1,000 to 10,000 during the course of radiotherapy. It is also associated with alterations in the saliva, where after 60 to 120 days, the taste loss becomes reversible and recovery takes place. Moving on to the salivary glands, the major salivary glands are also unavoidably irradiated to 20 to 30 grays of radiation during radiotherapy for cancer in the oral cavity or oropharynx. They are inevitably exposed even if it is not affected with cancer. And it is the parenchymal component of the salivary gland which is more radiosensitive, and usually the parotids which are much more radiosensitive than the submandibular and the sublingual glands. The first few weeks after initiation of radiotherapy, there is a progressive loss of the salivary secretion, which is called as hyposalivation. The mouth becomes dry, leading to xerostomia, making swallowing difficult and painful. There are many changes that can occur. There may be reduced in the volume of saliva in the patients. Saliva may become more viscous. The pH of saliva also becomes low enough to initiate decalcification of the normal enamel. The buffering capacity of saliva also decreases. But sometimes some portion of the major salivary glands are spared, and because of that, the dryness of the mouth usually regresses within 6 to 12 months. Reduced salivary flow usually persists beyond a year, and it may be associated with inflammatory response and sometimes leads to fibrosis of the salivary glands, which finally leads to xerostomia. Moving on to the teeth. Children receiving radiation therapy to the jaws may show defects in the permanent dentition, such as retarded tooth development, dwarfed teeth, or failure to form one or more teeth. If the exposure precedes calcification, irradiation may destroy the tooth bud. If irradiation is given after calcification has begun, it leads to malformation such as retardation or aborted root formation. But mind you, adult teeth are resistant to the direct effects of radiation exposure. The pulpal tissues also demonstrate a long term of fibroatrophy after irradiation. The next, the radiation caries. It is a rampant form of caries which affects individuals who receive radiotherapy that includes exposure to the salivary glands. As I've already mentioned, salivary glands are invariably affected when it is being irradiated for head and neck cancers. After radiotherapy, that includes the major salivary glands, the microflora also becomes acidogenic in the saliva, which causes increase in the Streptococcus mutans, Lactobacillus, and the Candida species. Caries also results from changes in the salivary glands and the saliva, which I have already mentioned, which includes the reduced salivary flow, decreased pH of saliva, reduced buffering capacity, increased viscosity with altered flora. Radiation caries is basically of 3 types, and the most common one affects the buccal, occlusal, incisal, and the palatal surfaces. Another type which involves the cementum and the dentine in the cervical region. These lesions may progress around the teeth circumferentially, which results in loss of the entire crown. The final type has the dark pigmentation of the entire crown, and sometimes the incisal edges may also be markedly worn. But there are also certain various ways to reduce caries. 1, we can try the application of sodium fluoride gel. 2, avoidance of dietary sucrose. Sometimes restorations could also be done, and the main thing is to educate the patient to maintain an excellent oral hygiene. Then the musculature. Radiation may cause inflammation and fibrosis, which results in contracture and trismus in the muscles of mastication. It is usually the masseter and the pterygoid muscles which are involved. It leads to the restricted mouth opening, which usually starts about 2 months after radiotherapy is completed. Treatment of oral cancers in the oral region often includes irradiation to the mandible or the maxilla. Usually, the mandible is more affected than the maxilla because of the increase in the vasculature or the blood supply. The primary damage to the mature bone results from radiation-induced damage to the vasculature of the periosteum and the cortical bone. This marrow tissue becomes hypovascular, hypoxic, and hypocellular following the 3H principles. Hypovascular, where there is decrease in the amount of blood circulation, hypoxic, decrease in the amount of oxygen supply to the bone, and hypocellular, decrease in the amount of cells. In addition, the endosteum becomes atrophic, showing a lack of osteoblastic and osteoclastic activity, which leads to bone death and osteoradionecrosis. So what is osteoradionecrosis? Osteo is bone, radio is radiation, necrosis is death of the bone. As per the definition given by White and Farrow, osteoradionecrosis refers to an inflammatory condition of the bone, which is osteomyelitis, that occurs after the bone has been exposed to the therapeutic doses of radiation, usually given for malignancies of the head and neck region. So as said, it is an inflammatory condition which affects the bone, which is usually irradiated during head and neck carcinomas. So this is one typical pictorial representation of a patient who was around 65 years old, came to our dental OP, who was diagnosed as carcinoma of the right side of the jaw. Further treatment could not be carried out here in our college, where the patient was sent to Pondicherry Medical College, and where he underwent radiotherapy. And the patient came back with this condition where there was the raw bone which was exposed. I think we will be able to visualize the base of the mandible which is exposed, and this is what is osteoradionecrosis, because the patient has undergone radiotherapy without further or trying to understand the patient in the previous visits, or trying to understand the oral hygiene of the patient. So what is the pathogenesis of osteoradionecrosis? So first, when there is irradiation of the mandible or the maxilla, the normal marrow space is replaced by the fatty marrow or the fibrous connective tissue. This will in turn become hypoxic, hypovascular and hypocellular. The endosteum becomes atrophic, showing lack of osteoblastic and the osteoclastic activity, which leads to reduced degree of mineralization, causing brittleness of the bone. Finally, the bone death, bone is exposed, which leads to osteoradionecrosis. According to Burkitt's 11th edition, osteoradionecrosis is classified into 3 stages. Stage 1, which categorized as resolved and healed. Stage 1A with no pathological fracture, 1B with past pathological fracture, and 2 chronic and non-progressive, with 2A with no pathological fracture and 2B pathological fracture. 3, which is active and progressive, and 3A with no pathological fracture and 3B with pathological fracture. So going on to the investigations of osteoradionecrosis, there is a typical representation of osteoradionecrosis, which is represented as the moth-eaten appearance, where you will have mixed radio-opacities and radiolucencies with poorly defined ragged borders. There may be enlarged and irregular trabecular spaces and evidence of sequestrum. Sequestrum will appear as radio-opacities where you have irregular borders of the bone. Osteoradionecrosis is treated with the following: prevention of recurrence, local wound care, hyperbaric oxygen therapy, and finally surgery. So there are certain things that we have to follow before the patient is subjected to radiotherapy, and during the therapy and after the therapy. So before the therapy, the patient has to undergo extraction of all questionable teeth, elimination of the oral foci of infection. Healing time of minimum of 3 weeks is required before we start on with any procedures. Adjustments of dentures, if required, has to be done before the procedure of radiotherapy. And during radiotherapy, extraction of teeth or any bone trauma is contraindicated. And we should be able to detect early caries after the treatment and not go in for any surgical procedures for a minimum of 12 months. And to summarize, we have tried to understand the rationale of radiotherapy, trying to understand what are the effects of radiotherapy on oral tissues, where we try to understand about the oral mucosa, the taste buds, the salivary glands, the teeth, the musculature, bone, emphasizing the importance of osteoradionecrosis. Thank you.